Presenting on behalf of Medicine 2. The title for my presentation is Seize the Opportunity. Presenting Mrs. S, a 47-year-old lady from West Bengal, who had presented with complaints of loss of appetite and weight for 6 months, rashes over the lower limbs for 6 months, and history of fever for 4 months. So she had lost around 13 kgs of weight over the last 6 months, and she developed these itchy rashes over the lower limbs. Initially, she noticed only over the lower limbs, and later she had noticed it over the upper limbs as well as the chest. She also developed low-grade intermittent fever associated with night sweats. Otherwise, there was no chills or rigors. There was no history of any joint pain, photosensitivity, hair loss, or ulcers, oral ulcers, and she had no cough with expectoration, breathing difficulty, no abdominal pain, loose stools, vomiting, or burning micturition, no headache, seizures, altered sensorium, or any neck stiffness. She has no comorbidity. She is not a known diabetic. And in the past, she was operated for nasal polyps and hemorrhoids. Personal history, there is no history of any high risk behavior. There is no history of any IV drug abuse, any extramarital affairs. There is no history of any blood transfusions in the past. So coming to the examination, at the time of presentation, she had a temperature of 100. There was pallor, and also she had multiple subcentimetric lymph nodes in the cervical region, in the multiple levels. And on examination, she also had multiple papillary erythematous lesions over the hands, over the legs, and over the chest. On the systemic examination, there was hepatosplenomegaly. So the liver was 3 centimeter palpable below the costal margin, and the spleen was also palpable 3 centimeter below the costal margin. The rest of the systemic examination was not significant. So this was a picture of the rashes that she developed over the lower limb. So summarizing, this is a lady who is presented with systemic illness. She's presented with history of low-grade fever, loss of weight, loss of appetite. There is reticuloendothelial system involvement in the form of lymph nodes and hepatosplenomegaly, and there is skin involvement. So at this point of time, the differentials that we considered were the following. Infections, we considered HIV with opportunistic infections, disseminated TB, histoplasmosis, cryptococcus, infective endocarditis, occult abscesses, and malignancies like lymphomas, HCC, RCC, and autoimmune like SLE, vasculitis, or sarcoidosis. So these were her initial investigations. The blood picture showed a pancytopenia. So we did a chest X-ray on her. I'm not sure if we can make out the multiple nodules. They are like the cannonball lesions that were present near the base of the lungs. So to characterize these nodules further, we did a cross-sectional imaging, which was reported at multiple rounded nodules in both the lungs, and there was features of hepatosplenomegaly with lymph nodes. So at this point of time, the radiologist as well as us, we were thinking more in terms of metastasis. At this point in time, is there any other investigation that you would like to do? That was missed. Okay, so one of our differentials are autoimmune and HIV with opportunistic infection. So we did the same. Autoimmune workup was negative, and we did BBVS, which showed which was HIV positive with a very low CD4 counts and high viral load. So at this point of time, what are the differentials? Okay, we'll continue the presentation. Okay. We did a bone marrow biopsy to evaluate for the pancytopenia, as well as we took lymph node biopsies from the lung nodules, and we also did a colonoscopy which showed colitis, and we took biopsy from those regions. So all had showed histoplasma. So the bone marrow culture as well as the biopsy showed histoplasma. The lung lesions, the nodules that was biopsied under CT guidance also showed histoplasma. Colonoscopy was done and biopsy was taken from these regions, showing and also cultures are taken, and all of that had showed histoplasma, and histoplasma antigen was also positive. So coming to the discussion, histoplasma is a dimorphic fungi. So it exists in both mycelia as well as yeast form. And the mycelia form has both microconidia as well as macroconidia. So the infective form is microconidia, which is actually enters the body by inhalation. It enters into the lungs and engulfed by the macrophages. And in that, it gets converted into the yeast form. So it multiplies within the macrophages and it spreads to other reticular endothelial system by the blood. So what is progressive disseminated histoplasmosis? So it is where it is present in multiple areas of the body. So the risk factors include immunodeficiencies, like in AIDS where the CD4 counts is less than 200, any primary or genetic immunodeficiencies, if the patient's on immunosuppressive drugs for any other condition, autoimmune malignancies, or if the patient's on steroids, extremes of ages, and diabetes. So how does PDH present? It can have an acute presentation as well as a subacute to chronic presentation. If it's an acute presentation, it's usually presents all the interstitial and reticulonodular lung infiltrates lead to rapid onset like respiratory failure, shock, coagulopathy, and other multi-organ dysfunction. If it's more of a subacute to chronic presentation, it presents with systemic symptoms like fever, weight loss, hepatosplenomegaly, pancytopenias, adrenal insufficiencies, GI lesions, or skin and mucosal lesions. So coming to the diagnosis, the gold standard is the culture. So the culture can be taken either from the bone or the bone marrow. We can do an antigen detection from either from the urine, serum, or the bulk, or cytopathologies. So if you see in the study, it shows that antigen detection is the most sensitive. So how do we treat the infection? According to the guidelines, there is an induction phase and there is a continuation phase. So induction phase is treated with amphotericin B, either the conventional or the liposomal. So if it is a conventional, the dose is around 0.7 mg per kg, given for 1 to 2 weeks. And if it's liposomal, the dose is 3 to 5 mg per kg, followed by itraconazole, usually for 1 year. So if the patient does not tolerate itraconazole, you can also use fluconazole, voriconazole, posaconazole. So this is an RCT that was done, which shows the efficacy of both liposomal amphotericin B and conventional amphotericin B. So in this graph, we can see, so what they did is they took patients with AIDS and disseminated histoplasmosis, and in the interventional arm, they gave liposomal amphotericin B, and in the control arm, they gave conventional amphotericin B. So they looked at clinical success, blood culture negativity. So in this graph on the top, you can see like by day 3, there is fever, like there's effervescence in both the arms, both liposomal and conventional amphotericin B. But by day 14, the patients who received liposomal amphotericin B were less likely to have fever. But it was not, so when they calculated, it was not statistically significant, but the side effects were more in conventional amphotericin B due to nephrotoxicity. And coming to itraconazole, this is just a new type of itraconazole. It's called the suba itraconazole. It's a new formulation which actually uses nanotechnology. So basically, it improves the bioavailability. So there's only like one study that has been done. So actually the drug concentration for both are comparable. It's the same. It's only that the advantage is that using suba itraconazole, you can give a lesser dose. So there's lesser toxicity. So coming back to our patient was treated with amphotericin B for 14 days, and she was started on maintenance itraconazole. She was started on PCP prophylaxis, and Mycobacterium avium complex prophylaxis. And she had actually gone back to her hometown, following which she was planned to start on ART. Thank you.
Thank you, Tephilah, for the presentation. Any questions?
What about spouse screening?
It was negative.
What about VDRL, hepatitis B?
VDRL was negative. Hepatitis C was also negative.
On this examination, hepatitis?
It was negative.
Cryptococcal antigen?
Cryptococcal was negative.
So it's such low CD4 cell count. It's important to screen for other options. You know that multiple OIs is very interesting.
This patient maintenance, how long are you planning to give?
1 year.
1 year. Does he have an adrenal involvement also?
Sorry?
Adrenal was involved?
No, sir.
Adrenal involvement becomes a little difficult to treat. Usually we give antifungals for a longer period.
So
what's your experience?
By Dr. Tephilah from ID. So from our hospital, to compare PLHIV with the non-PLHIV, isn't that this? Adrenal involvement is almost exclusively not HIV. PLHIV is like